as Dr. van Rensburg just said, I'm going to talk about what does the gynecologist need to know about bladder pain. Estimated 19% of women of reproductive age suffer from chronic pelvic pain. And chronic pelvic pain can be further divided into lower urinary tract causes, female genital tract, GIT, musculoskeletal, neurological, physiological, and sexual dysfunction. I will focus on bladder pain syndrome and gynecological disorders often associated with bladder pain syndrome. Bladder pain syndrome is also known as interstitial cystitis, and we all know how we feel once you picked up that file, the chronic pelvic pain patient in gynae clinic. So what is bladder pain syndrome or interstitial cystitis? The International Continence Society used the term painful bladder syndrome is defined as the complaint of suprapubic pain related to bladder filling, accompanied by symptoms such as increased daytime and nighttime frequency in the absence of proven urinary or other obvious pathology. The American Urology Association uses a much broader term. They say it's an unpleasant sensation which includes pain, pressure, or discomfort perceived to be associated with the urinary bladder for longer than 6 months once you've excluded infection or other cause. So that means anyone that thinks they've got pain due to their bladder. Why is it of importance? 1 in 4 women, if you go according to the symptoms, has bladder pain syndrome. There's only 14 in 100,000 diagnosed with bladder pain syndrome. So we're clearly missing quite a big part. Women are 10 times more likely to be affected by painful bladder syndrome. It is part of the chronic pelvic pain spectrum, which means you need to look for it to be able to diagnose it. And there's a clear association with other pain syndromes such as fibromyalgia, migraine, chronic fatigue syndrome. Bladder pain syndrome in the gynecologist, I'm going to look specifically at the pelvic floor dysfunction, endometriosis, vulvodynia, I'm not saying that correctly, and pudendal neuropathy. So pelvic floor dysfunction can cause pain from the anterior, apical, or posterior compartment of the vagina. We find 2 subgroups, hypotonic and hypertonic disorders. And we in the hypertonic group, we most often find muscle tenderness, muscle trigger points, spasms, and voiding dysfunction. It has been estimated that the prevalence in hypertonic pelvic floor dysfunction in patients with bladder pain syndrome ranges between 50 and 70%. As we just heard, that the whole pelvic floor dysfunction is much more complicated than just the vesicomuscular reflex, but that has been implied that that is a reflex that you should activate occasionally as a protective measure, but in these patients, they are chronically in hypertonic state, and they don't know how to relax. On examination, like Dr. van Rensburg just explained, you need to specifically look for those trigger points. So it can be elicited by a single finger vaginal examination where you feel for a taut band. They often say it feels like you're stepping off a step, and that will also elicit the pain and the referral pattern of that pain as well. Treatment, pelvic floor physiotherapy. It's like they've explained it to me, like if you have a tight bicep and it's tight, you can't do anything with your arm. You need that muscle to relax for it to be able to contract again, and that the pelvic floor physiotherapists are trained to teach a patient to do that. So to regain movement in that muscle, you first must be able to relax that muscle. Endometriosis, also something that we often see. Up to 70% of women with endometriosis have a pain syndrome or a pain complaint, mostly dysmenorrhea, cyclic pain, or deep dyspareunia. But there's a high prevalence and association also with bladder pain syndrome. When we look at a recent systematic review, they show that there's a 48% coexistence of bladder pain syndrome and endometriosis. So once you've got it, this data suggests that once you've got a patient with endometriosis, you need to consider the bladder, especially in a patient that you've addressed the endometriosis and she still has pain. Just look a little bit further, it might be her bladder. Vulvoedenia or vestibular edenia, which according to International Society of the Study of Vulvovaginal Diseases, is a discomfort, often described as a burning pain occurring in the absence of relevant visible findings or a specific clinically identifiable neurological disorder. There's also a 25% overlap. The standard clinical test to elicit this and to diagnose this is the Q-tip test, measuring the pain and also mapping the pain, and in combination with visual analogs, a pain visual analog scale. So the pain can be either burning, stabbing, aching, or a pressure symptom induced by voiding, defecation, or vaginal penetration, and it can be anywhere of in that area. The treatment is gabapentin, and more recently there is actually data to support Botox injections. In this specific research that I've read about, 8 out of 11 patients reported an improvement, and it improved their pain score from 8 till 2, but it still needs to be investigated further. So for this specific complaint, there is research regarding Botox injections.
Can we interrupt you?
Yes.
So a lot of the chronic pain theory in chronic pelvic pain goes around cycles.
Yes.
And cycles are established. Even when the primary stimulus is removed, the cycle is established.
Yes.
And so it's important to break the cycle
Early. Yes.
And Botox is a temporary solution. But if you break that cycle, if you get it in early, is it something that you don't have to give recurrently then because you've broken the cycle?
I think it depends on the cause. So if it was solely a pain cycle that is now activated and is now just firing unnecessarily, and you remove that cause, then it will help. But if the cause is that there is a specific pain stimulus still firing, even though, so I think it depends on the reason for the cause of the pain. If it is it's clearly just the pain syndrome that's causing it, and there's no stimuli anymore, then I think it will help and you won't need recurrent treatment. Or it might just be a bridge for you to establish another treatment modality. I don't know if I answer your question properly. Yes. So the next one is Pudendal Neuropathy. So this is a functional entrapment of pudendal nerve and pain occurring during compression or stretch maneuvers. The main symptom is pain aggravated by sitting, driving, or exercise, reduced whenever you're leaning onto something or by just standing up, and is relieved by sitting on the toilet. There's often a foreign body sensation in the rectum, the vagina, the urethra, or the perineum is often reported, and you can have pain throughout the whole pudendal area nerve supply, ranging up to the inner thigh. It's also associated with features of dysfunctional voiding, non-obstructive urinary retention, chronic pelvic pain syndromes, and urinary and fecal incontinence. In those specific syndromes, you will need to look for pudendal neuropathy. The management of pudendal neuropathy is firstly pharmacological. Tricyclic antidepressants have been shown to work well. Minimal invasive procedures such as transgluteal pudendal nerve block, and in specific cases, surgical management of nerve decompression. And there's different approaches. Transperineal, which is a blind procedure. Transgluteal and transvaginal is now newer approaches that's being investigated. What a gynecologist should know about bladder syndrome, painful bladder syndrome. It's like you could hear from the definition, it's still there's a lot of confusion and uncertainty and still not much clarity on what causes painful bladder syndrome. These are all the different options that has been postulated. So the first is, I'm just going to quickly go through them. Immune cell activation. There's 2 cells that they think could be causing the painful bladder syndrome. Mast cells is being activated, causing the release of histamine and other pro-inflammatory mediators, and as well, and then subsequently causing fibrosis, pain, frequency. Also, plasma cells that's being activated that influences the chemostaxis of inflammatory cells to the inflammation site. And this is actually mostly seen with the subgroup of patients with hernia lesions on cystoscopy. You see this, the immune cell activation. Then the new buzzword in the urology and painful bladder syndrome is the increased that was the previous big thought, was the increased permeability of urothelium due to urethral dysfunction. So there's a belief there's a protective barrier of glycosaminoglycans and intercellular junctions. And they thought it's a dysfunction of that layer and a permeability of that layer that causes the painful bladder syndrome. But we're actually moving away from that, moving towards the inhibition of the bladder urothelial cell proliferation. And they've seen that in patients with bladder pain syndrome, there's actually a decrease in urethral cell proliferation, and with that, an increase in anti-proliferation growth factor. And that is being secreted in the urine, which you can test, and is thought to be a good biomarker that has got good specificity and sensitivity to diagnose painful bladder syndrome, but it's still being investigated. So in that case, your bladder does not regenerate its endothelium as it should, and that could cause the painful bladder syndrome. There's also postulation of autoimmune mechanism, but that hasn't been seen throughout the patients. There's only a small portion that has autoimmune antibodies, and that doesn't explain the rest of the patients that there's no antibodies. Infection, there's no clear microbial organism that's been identified. There is talk about nanobacteria that could be causing it, but it's also inconclusive, as well as the change in the urine microbiome, also inconclusive. There's definitely a contributing factor with neurobiology and pelvic crosstalk, where the noxious stimuli increases the sensory and the sympathetic nerve activation, and that is also why we often see an overlap between painful bladder syndrome and IBS, irritable bowel disease or syndrome, because we've seen that it's linked to the neurology and the innovation. Then there's a theory thinking that it could be due to urinary toxic agents. They've seen there's a specific protein, sorry, need to get to that name. The TAM-Harsful protein that neutralizes cations in the urine, and they've seen that there's a decrease or glycosylation of that protein in patients with painful bladder syndrome. So is it that? Could be, but they also see this toxic urine in patients without painful bladder syndrome. So it's not isolated to this. And then the last one is hypoxia. They see on cystoscopy that there is a decrease in microvasculature, as well as soon as you hyperdistend the bladder, that there's less perfusion. But it's still unclear what caused the initial hypoxia, or what triggers this. So, what causes painful bladder syndrome? This is what our patients have a problem with. So diagnosis, if we leave the anti-proliferative growth hormone on the side for a bit, is a clinical diagnosis based on a thorough history and examination, and excluding other causes of infection or another cause of the pain. So doing a good, thorough history, focusing especially on sexual history and psychological history, as psychological problems can be a big contributing factor, as well as diet. Examination, we will focus on the bladder, neck, suprapubic tenderness, levator any trigger points, and cervical excitation tenderness. You should always do a bladder diary and a clinical pain score, not only to diagnose, but also to see the efficacy of your treatment in a patient that's presenting with these complaints. Urodynamics and cystoscopy is not used to diagnose painful bladder syndrome, but to exclude other causes of the pain. Differential diagnosis, you need to look at everything. So exclude bladder or urethral malignancy or stones, exclude infection, exclude overactive bladder or urine retention, any inflammation or metaplasia, a urethral diverticulum, pelvic organ prolapse, gynecological cancer, vaginitis, endometritis, pelvic nerve neuralgia, and morphine-induced hyperalgia. Treatment, the American Urology Association put the treatment in 6 tiers of treatment, which made it easier to go about in a stepwise manner. You will see our first line treatment is general relaxation, stress management, analgesia, patient education, support group, self-care, and behavioral medication. So this can hurt no one. If you have a patient that maybe, and this will help any pain syndrome patient, if you can equip them to look at the basics first. So first line treatment is all of those. Second line treatment, physiotherapy, as we've just heard. Oral therapy, we can look at analgesia. Amitriptyline is a cholinergic receptor blocker, which can also stop the hypersensitivity due to the recurrent nerve activation. Hydroxyzine is, other name is Atrax. It's a histamine 1 receptor blocker, also is shown to have good efficacy. Cimetidine has actually been proven by randomized control studies to show an improvement of up to 40%. Pitosan polysulfate is a heparin-like molecule that restores the gag layer. So that is something that is very often used, but it takes time. You have to give it for a prolonged time before it will reach its maximum efficacy. So you may need to add something in the meanwhile or use different things together to get the best results. Then we've got intravesical therapies. Dimethyl sulfoxide, DMSO, is something that was discovered in the 1866 by the veterinary medicine. And this is actually the only medicine that's FDA approved for intravesical treatment of painful bladder syndrome. But unfortunately, it causes initial urethral damage and can cause voiding dysfunction, but that is temporary of nature, and it actually also shows to have a better efficacy if given in conjunction with IV HEP, local anesthesia, sodium bicarbonate, and steroids. So most often it is given in conjunction with or in a cocktail with other ingredients, other modalities. Third line treatment is cystoscopy under anesthesia and hydrodistension. That is often also used in diagnosis, and it has been shown to give some relief in a specific group of patients. If there's a hernia lesion, vulgarization either by cauterization or with injection of steroids has been shown to have a very good effect if there is a hernia lesion. They are the only patient that you can have months of 100% improvement of their pain if you do that. So just some to keep everybody awake at the end. What food should someone with bladder pain syndrome avoid? Do you know? What do you, so we can tell them, Deirdre? Citrus. Judy? Yes. So fruit juices, tomatoes, carbonated beverages, coffee and tea, multivitamins. So does it really make a difference, or do we just fool them? A randomized study by Foster et al. That was published in the Journal of Urology in 2010 showed a 45% improvement, moderate to marked improvement in their symptoms, just by teaching the patients how to manage their symptoms, control fluid intake, change their diet, and bladder training. So that is our first line of treatment. Then if we go to the more specialized treatments, fourth line treatment is intertracheal Botox injections and neuromodulation. So Botox injections, there's still not clear evidence that it works for painful bladder, but it has been indicated for overactive bladder, and it looks like there is some improvement. Neuromodulation, sacral nerve stimulation has been shown to improve the symptoms, so that can be considered. Fifth line treatment, cyclosporin, that is based on the autoimmune theory behind painful bladder syndrome. It's reserved for fifth line treatment because it's got quite severe side effects like nephrotoxicity and immune suppression. And only very, very specific cases you can consider surgery. But the reality is that the patient could still have pain even though she had a diverging surgery done. So this is a very complex disease. We all need to know about it. Like I said, if you don't know about it, you can't diagnose it, you can't look for it. And your patient might just need someone to ask the right questions. I've had a patient recently in the gynae clinic that she said for the first time someone is asking the right questions. So the patients are out there, we just need to find them. And the importance with painful bladder syndrome is to realize that it's a pain syndrome. So it's not just removing the cause. It's a biopsychosocial approach to this patient. She's been living with this pain most likely for up to 7 years, and you can help her to address this. Yes, thank you. Any questions?
I think it's late in the afternoon, but maybe I should ask you a question. I think it's very important because you're going to see patients with pain. And it is like the taboos that Louise talked about. When you don't know much about it, you're going to shy away from it. So you're going to have to develop an approach to a patient with pain. So I think she touched on a few things, but I think what we have to know is that the most gynecologists, if there's chronic pain, they're going to do a laparoscopy. They want to look for endometriosis. And once you don't see endometriosis, you can say to the patient, everything is fine, it's clear that there's no organs on there. And I think if I can just say something about the talk that we had here and the talk that we had with Louise, is that if you're going to look a little bit further and you have an approach, with your history, clinical examination, how you're going to look at the pelvic floor, you're going to very often find something that you can treat. But if you get somebody like this with symptoms of the overactive bladder syndrome, with pain when they fill, the first thing the gynecologist also probably needs to know is she's going to refer to is that patient needs a cystoscopy. You have to rule out pathology. And once you know that, you can start, because you really need to investigate that patient. If you're going to miss the bladder, you might miss a cancer. This is what I want to just emphasize on that. She illustrated to you, you have to do this. So to see it in context, what do you think? What is the most common? Endometriosis or painful bladder?
Pain syndrome, not non-specific, but we can't find anything, so
painful bladder is way more common than gynecology reasons. If you can go out and remember that today, then help a little bit further widen the horizons. So thank you very much, Nick.
Great.